Re-establishing neuromuscular control. So let's start off by examining what is neuromuscular control. We have signals that are transmitted through afferent sensory pathways. We have several terms that we need to explore: proprioception, kinesthesia, and neuromuscular control. Proprioception is the conscious and unconscious appreciation of joint positions in space. This is our awareness of the position and the movement. This includes any postural, positional, or kinetic information provided to the central nervous system by sensory receptors in the muscles, tendons, and joints. Kinesthesia is the sensation of the joint motion or acceleration. This is our sensation of active movement or contracting the muscles. So neuromuscular control is an efferent motor response to sensory information. This includes both proprioception and kinesthesia. The conscious awareness of joint motion, position, and force are all essential for motor learning. Unconscious proprioception is the key for muscle function and initiating a reflex joint stabilization. There is a motor control mechanism, both a feed-forward and a feedback neuromuscular control. Feed-forward neuromuscular control includes planning movements based on sensory information from past experiences and preparatory muscle activity. A feedback neuromuscular control includes continuously regulating muscle activity through reflexive pathways. This is reactive muscle activity. Muscle activity enhances the joint stability. This increases joint congruency, provides an eccentric absorption for external loads, and increases muscle stiffness. Muscle activation can modify muscle stiffness properties, or the ratio in the change of force to the change in length. A stiffer muscle resists stretching and becomes more effective in restraining joint displacement. High stiffness limits fast joint motion that is necessary for physical activity, though. So stiffness must be regulated continuously during activity. Muscle stiffness regulation may embody all of the components of the dynamic restraint system. This is critical for restoring functional stability. What is the role in the rehabilitation process for neuromuscular control? This refocuses the patient's awareness of peripheral sensation and processes them in more coordinated motor strategies. This is required to protect joints from excessive strain, and it also provides prophylactic mechanisms for recurrent injury. This complements our traditional components of rehabilitation. The primary role of the articular structures are to stabilize and guide body segments. They provide mechanical restraint to abnormal joint motion. The capsule ligamentous tissue has a sensory role that is essential to detect joint motion and position. Injury results in damage to microscopic nerves associated with the peripheral mechanoreceptors. This disrupts the sensory feedback. It also alters reflexive joint stabilization and neuromuscular coordination. It also affects the dynamic restraint system. The dynamic restraint system capability becomes minimized following injury. After surgical intervention, we see a need to restore mechanical stability. During healing, there is a reinnervation of graft tissue by peripheral receptors. The surgical intervention and rehabilitation both should support neuromuscular characteristics for key dynamic stability. Rehabilitation should address the feedback systems, both the preparatory or feed-forward and the reactive or feedback system. There are four crucial elements: joint sensation, including the position, motion, and force; dynamic stability; the preparatory and reactive muscle characteristics; and the conscious and unconscious functional motor patterns. All of these play a role in neuromuscular stabilization. The physiology of the mechanoreceptors. Let's start with articular mechanoreceptors. These are specialized nerve endings that transduce mechanical tissue deformation into frequency-modulated neurosignals. An increased tissue deformation results in increased afferent firing rates, or a rise in the quantity of mechanoreceptors that are activated. There are different types, including the Pacinian corpuscles, Messinian corpuscles, and the free nerve endings. Some of these are quick adapting, also known as QA. They cease discharging shortly after onset of a stimulus and provide conscious and unconscious kinesthetic sensation in the response to joint movement and acceleration. Others are slow adapting, or SA. They continue to discharge as long as a stimulus is present. This continuous feedback and proprioceptive information are relative to the joint position in space. Neuromuscular mechanoreceptors. Let's start with the muscle spindles. These detect the length and the rate of length changes. Muscle spindles transmit information via the afferent nerves. They are innervated by small motor fibers, also known as gamma efferents. They project directly on the motor neurons, or a monosynaptic reflex. When muscle spindles are stimulated, a reflex contraction in the agonist muscle occurs. Next are the Golgi tendon organs, also known as the GTOs. These regulate muscle activity, tension, and load. They are located in the tendon and the tendomuscular junction. The Golgi tendon organs serve as force detectors. They are reflexively inhibiting muscle activation when excessive tension that may cause damage occurs. With activity, moderate levels of muscle tension may reverse the reflex, or in other words, the muscle tension resulting in muscle recruitment. They are opposite of the muscle spindle. They produce a reflex inhibition or relaxation during muscle loading. Last are the cutaneous receptors. These include pressure and stretch receptors located in the skin. They contribute to proprioception, kinesthesia, and force sense. The involvement in force sense is intuitive. Joint motion can also cause skin stretching and a compression on either side of the joint during a motion. Neural pathways of peripheral afferents. Encoded signals are transmitted from peripheral receptors via the afferent pathway to the spinal cord. Interneurons link ascending pathways to the cerebral cortex. This permits conscious appreciation of proprioception and kinesthesia. Sensory information from the periphery is used by the cerebral cortex for somatosensory awareness, and also for a feed-forward neuromuscular control. This includes balance and postural control. Balance and postural control are both processed at the brainstem level. Balance is influenced by peripheral afferent mechanisms, mediating joint proprioception. Balance is partially dependent on the inherent ability to integrate somatosensory input, which includes joint position sense and kinesthesia, with vision and vestibular apparatus with the neuromuscular control. There is a disassociation between these sensory modalities that may contribute to an exaggerated postural sway. Balance is frequently measured to detect deficits in the afferent feedback loop. The spinal cord links afferent fibers with efferent motor nerves. This contributes to the dynamic stability using feedback processes for reactive muscular activation. Interneurons connect articular receptors and Golgi tendon organs with large motor nerves innervating muscles and small gamma motor nerves innervating muscle spindles. The articular afferents have potent effects on the muscle spindles. The muscle spindles regulate muscle activity through a stretch reflex. The articular afferents have influence on the skeletal motor nerves and tendomuscular receptors via the gamma motor nerves. The final common input includes the articular and tendomuscular length. Muscle spindles integrate peripheral afferent information and transmit a final modified signal to the central nervous system. This feedback loop is responsible for continuously modifying muscle activity through a stretch reflex. Reflexes derived from peripheral mechanoreceptors contribute to dynamic joint stability. Increases in muscle length due to joint perturbation excite the muscle spindle afferents. The afferent volleys, which then produces a spinal, which is typically a short latency, a medium latency, or a long latency stretch reflex response based upon the extent of the central processing. This provides us with a heightened resistance to further muscle lengthening, thus resisting joint motion. Mechanoreceptors and ligaments can elicit a reflexive response in musculature to resist loading as well. There is a feed-forward and a feedback neuromuscular control. The feed-forward neuromuscular control is also known as the pre-activation theory. Prior sensory feedback or experience is used to pre-program muscle activation patterns. These are responsible for preparatory muscle action and high-velocity movements. This increased muscle activation will enhance the stiffness properties of the muscle. This leads to improvement in the stretch sensitivity and reduced electrical chemical delay. This leads to improvement in stretch sensitivity and reduced electrical chemical delay. This improves the reactive capability added by the sensory input and superimposed stretch reflexes on the descending motor control command. The feedback neuromuscular control. This continuously adjusts muscle activity via the reflexive pathways. It may result in a long conduction delay and is best for postural adjustments and slow movements. Reflex-mediated dynamic stability is related to speed and the magnitude of perturbation. Both systems enhance dynamic stability, and repetitive activation of the synapses results in further facilitation. We have memory recall of the signal, which enhances the function of that signal. Exercises must be executed with precision, repetition, and controlled progression for a physiological adaptation to occur and to enhance the neuromuscular control system. Reestablishing neuromuscular control. Injuries result in deficits in the neuromuscular control. The pathoetiology. Injury results in de-afferentation of the ligament and capsular mechanical receptors. Joint inflammation and pain compound the sensory deficits. Congenital or pathological joint laxity have diminished ability to detect joint motion and position in space. This results in effects on the proprioception, kinesthetic deficits, and mechanical instability may further lead to functional instability. The objective of neuromuscular rehabilitation should be to develop or reestablish the afferent and efferent characteristics that enhance dynamic stability. The elements include proprioceptive and kinesthetic sensation, dynamic joint stabilization, reactive neuromuscular control, and functional motor patterns. The dynamic elements may be compromised due to de-afferentation and can result in a functionally stable joint. Afferent and efferent characteristics include the sensitivity of peripheral perceptors, facilitation of afferent pathways, muscle stiffness, the onset rate and magnitude of muscle activity, agonist and antagonist co-activation, and reflexive and discriminatory muscle activation. Rehabilitation techniques should allow these characteristics to be modified, thereby impacting dynamic stability and function. Activities for inducing adaptations. Open and closed kinetic chain activities can be used, as well as balance training, eccentric and high repetition low load exercises, reflex facilitation, stretch shortening cycles, biofeedback training, and the use of vulnerable position training. Traditional rehabilitation should be paired with specific techniques to result in beneficial adaptations to the neuromuscular characteristics responsible for the dynamic restraint and improved functional stability of the individual. Neuromuscular characteristics. The peripheral afferent receptors are the foundation for the feedback mechanisms. Altered peripheral afferent information may disrupt motor control and functional stability. Open and closed kinetic chain exercises and receptor stimulation can help. Repetitive athletic activity enhances proprioceptive and kinesthetic acuity, which facilitates the afferent pathways. Enhanced joint motion awareness improves feed-forward and feedback mechanisms. Muscle stiffness plays a significant role in the preparatory and reactive dynamic restraints. We should encourage exercises that encourage muscle stiffness, and it should be incorporated into the rehabilitation program. This includes things such as eccentric exercises. Chronic overload results in connective tissue proliferation, desensitizing Golgi tendon organs and increasing muscle spindle activity. Power training and endurance-trained athletes. In power training, faster muscle pre-activation should be utilized, possibly utilizing EMG technology. For endurance athletes, increased baseline motor tone is important. Reflexive muscle activation. Training modes cause neuromuscular adaptations that account for differences in the reflex latency times between power and endurance-based patients. Preparatory and reactive muscle activation might improve with dynamic stability and function. Preparatory and reactive muscle activation might improve dynamic stability and function if muscle stiffness is enhanced in deficient joints. Decreasing electromechanical delay between joint loading and protective muscle activation can increase stability and function. There is an optimal stiffness regulation that is critical to both stability and function. Challenges associated with surgical reconstruction. Controlled loading is necessary to facilitate ligamentization. Sensory information is often compromised due to lost mechanoreceptors. Rehabilitation processes should facilitate reinnervation of graft tissue by peripheral receptors and reestablish ligament stress-elicited reflexes. Finally, discriminant muscle activation. This is the unconscious control of muscle activity that is critical in balance and coordination. Restoration of the force couples may initially require conscious activation prior to unconscious control. Use of biofeedback can aid in this process, which helps eliminate imbalances and re-establish preparatory and reactive muscle activity. The elements for neuromuscular control: proprioception and kinesthetic training. This restores the neurosensory properties, enhancing sensitivity of the uninvolved peripheral afferents. Joint compression is believed to maximally stimulate articular receptors. This should be addressed by utilizing closed-chain exercises through the available range of motion. Early repositioning tasks are critical. This includes the conscious to unconscious joint awareness. Applying a neoprene sleeve or an ACE wrap may stimulate the cutaneous receptors and provide additional proprioception and kinesthesia during rehabilitation. Dynamic stabilization. This encourages the preparatory agonist and antagonist co-activation. It also restores force coupling and balances the joint forces, resulting in decreased loads on the static structures. Activities that require anticipatory and reactive adjustments to imposed loads should be utilized. The combination of balance and stretch shortening exercises are recommended. This encourages the preparatory and reactive muscle activity. Closed-chain exercises induce co-activation and compression. Reactive neuromuscular control. This stimulates the reflexive pathways. The objective is to impose perturbations that stimulate the reflex stabilization. This can result in decreased response time to develop reactive strategies. And the development of reactive strategies to unexpected joint loads. Perturbations should be unexpected in order to facilitate this reflexive activity. And finally, functional activities. The objective is to return the athlete to pre-injury activity. This may involve sport-specific movement patterns designed to restore functional ability. We can use this to assess the readiness for return to play. We should stress the peripheral afferents, muscle co-activation, and the reflexive activity during this process. We should help our patient to develop functionally specific movement patterns, ultimately decreasing the risk for injury or possible re-injury. Some lower extremity techniques. Techniques should focus on muscle groups that require attention, progressing from no weight to weight assisted. The use of close kinetic chain activities is encouraged to increase joint compression, congruency, and neuromuscular feedback minus the shear forces. Joint stabilization exercises may include balance and partial weight-bearing activities, progressing from non-weight bearing to full weight bearing, and balancing on an unstable surface can begin once full weight bearing is possible. Other examples include slide board exercises. This stimulates the co-activation with increasing muscle force and endurance, and stimulates the dynamic stability and stiffness. Stair climbing, either forward or backward, emphasizes the eccentric strength. Biofeedback is used to develop agonist and antagonist co-activation and encourages voluntary muscle activation. The stretch shortening exercises are eccentric deceleration and explosive concentric contraction. We incorporate this early in the rehabilitation process, but with modified loads. This may involve preparatory and reactive muscle activity. This could include something like a hopping progression, going from a double to single leg hopping, or sagittal to lateral and rotational hopping. And we can also modify the surface. Rhythmic stabilization is a reaction to joint perturbations. We have a preparatory and reactive muscle activity. We see alterations in loads and displacement in the joint. Unstable surfaces, linear and angular perturbations can alter the center of gravity. This facilitates the reflexive activity. Ball tosses with a disrupted concentration or increasing cognitive load during the ball toss could help. Trampoline hopping. Hopping and landing, either double support, single support, or in a rotational pattern, may challenge the athlete. We can also have them hop and catch or hop and land on varying surfaces. Last are functional activities. The goal should be to restore normal gait. Athletes must internalize normal kinematics such as the swing and the stance phases. We can use retro walking, inducing hamstring activity, or pull or unloading devices. Crossover walking, figure eights, cutting, karaoke, or changes in speed can also be utilized. We would like to have functional activities that stimulate the demands of the sport. Upper extremity. We need to work to maintain joint congruency and functional stability. This requires the dynamic restraint via coordinated muscle activation. We need to address injury to our static stabilizers. Failure of the dynamic restraint system could result in repetitive loads compromising the joint integrity and predisposing the athlete or patient to re-injury. We can adapt some lower extremity exercises for the upper extremity. We need to be mindful of the muscles that have stabilizing roles and those that initiate movement. Injury to static structures can impact sensory feedback and impact the joint kinematics. Injuries to dynamic restraint mechanisms expose static structures to potential injurious mechanisms. Neuromuscular control is critical to reestablish in the upper extremity. Scapular control early in rehabilitation is imperative. Scapular retraction and protraction must be addressed. The role of the lower trapezius and the serratus anterior are critical. Closed kinetic chain activity should be used to promote afferent feedback and muscle co-activation. We use the stretch shortening or plyometric exercises. We can also encourage multiplanar repositioning exercises to increase range of motion. Muscle stiffness can be utilized to enhance elastic resistance or focus on eccentrics. High repetitions and low resistance. Upper extremity ergometers should be incorporated for endurance. Dynamic stabilization, stability platforms, push-ups, horizontal abduction, Tracing circles on a slide board with the dominant and non-dominant arms may also be used, along with plyometric exercises. Reactive neuromuscular exercises may include manual perturbations, rhythmic stabilization with gradual progression, and placing the joint in inherently unstable positions. Our functional activities for the upper extremity. We should work on developing motor patterns in the overhead position. This reproduces the demands of activity. The greatest emphasis should be placed on technique. Re-education of the functional patterns is imperative. The speed and complexity in movement requires rapid integration of sensory information to be successful. Here are some additional exercises that could be utilized. There are so many exercises that can be utilized. The possibilities are endless. You need to use your imagination and get creative.